It is February 11th, 2026. And if you've been scrolling through the news feeds this morning, you might have noticed something brewing at the Department of Veterans Affairs.
Mm-hmm.
But this isn't the usual, government bureaucracy is slow story. This feels different.
Oh, it's very different. We are looking at numbers that are, frankly, hard to wrap your head around.
Right.
We're not just talking about a policy tweak here or there. We're looking at a potential $1 trillion shift in how care is contracted, a complete redrawing of the map.
And a huge controversy in Los Angeles that's kind of a lightning rod for the whole system.
Exactly.
It really feels like we're watching a collision in real time. On one side, you have this high-level policy executive orders, billion-dollar contracts.
And on the other side, you have this grassroots outrage, the gritty reality of what it actually takes to get a veteran into a home or a doctor's office.
And somewhere in the middle of all that,
Tucked away, almost quietly, there's some genuinely groundbreaking medical science happening that could change lives overnight.
So our mission for this deep dive is to connect those dots. We've combed through Federal Advisory Board transcripts, specifically Recommendation 2501 from the LA Board.
And some leaked internal discussions from HR, new legislation like the Beacon Act, and all the latest medical research briefs.
We're going to unpack how the VA is trying to balance this idea of world-class care with what looks like a massive overhaul of its own DNA.
And we really have to start in West Los Angeles, because if you want to understand the tension in the entire VA system right now, you just have to look at this one campus.
The West Los Angeles VA campus. Historically, they called it the crown jewel of veteran care. It's this massive piece of land.
Huge.
And correct me if I'm wrong, but this land was given to veterans, way back in the 1800s, right? It wasn't just bought by the government.
That's right. The 1888 deed specifically dedicated the land as a home for soldiers, but right now, it is the battleground for a very specific, very modern vision.
A vision coming from the top.
Directly from the top, Executive Order 14296, issued by President Trump. It mandates the creation of a National Center for Warrior Independence right there.
Warrior independence.
All right.
That sounds... Well, on the surface, that sounds ambitious. It sounds good. What does it actually mean in practice?
The language talks about self-sufficiency and warrior ethos. But the operational mandate is the kicker. It calls for the capacity to house up to 6,000 homeless veterans on that campus by 2028.
6,000. That's a massive number. But here's where I get confused. We have a homelessness crisis. Everyone agrees on that. So if the president says build 6,000 beds, why is the local board fighting back?
The Veterans Community Oversight and Engagement Board, yeah.
They came out with a recommendation to cap it at 1,200 units. Why would they want fewer homes for veterans?
It's a totally valid question, and it comes down to the philosophy of care. What is a home? The board argues that if you pack 6,000 people, many with high needs, trauma, addiction issues...
It's all into one campus.
All onto one campus. You aren't creating a community. You're creating an institution. They use the word warehousing.
So they're worried about creating a kind of ghetto, an island where veterans are just stuck together, separated from the rest of society.
But precisely. That's their fear. They want a hybrid model where most veterans are integrated into actual neighborhoods, living next to civilians, shopping at normal stores.
Not isolated on a federal reservation.
Right. They're worried 6,000 units just creates a sterile institutional housing project.
This connects to that debate over the town center we saw in the transcripts. Board member Mike Canfield was really, really emphatic about this.
He was. He kept saying a town center with a capital P.
And he didn't mean architecture.
No, not at all. He means social infrastructure. If you have 6,000 people living somewhere, you need more than a roof. You need a place to congregate, to run businesses, to have a social life.
He said he didn't want just storefronts bolted onto residential buildings.
That was the quote. His point is that the current plan treats these units like storage lockers for humans. He wants a real community hub.
But the executive order is pushing for the number,
Yeah.
the capacity.
Exactly. And when you're under a federal mandate to hit 6,000 beds by 2028, the nuance of a town center or social fabric, that often gets value engineered right out of the plan.
You build the box, put the veteran in the box, and check the box on the spreadsheet.
That's the fear.
And meanwhile, while they fight over the future, the current reality on the ground seems messy. The public comments from those meetings, the anger is palpable.
It is intense. You have advocates like Rob Reynolds and Senate Devermont who just hammer the administration. They're pointing out what they see as a glaring hypocrisy.
Okay, what is that?
Well, while the government says there's no land or no money for certain things, there are still these what they call illegal leases on the property.
And this goes back to that 1888 deed you mentioned.
Yes. Remember, this land is for soldiers. Yet you have the Brentwood School, a very wealthy private school using athletic fields on VA land. UCLA is using land for a baseball stadium for parking.
So the question is, why are private school kids playing baseball on land that should be housing homeless vets?
That's the question they keep asking.
It's a stark contrast. And speaking of contrast, there was one story from those comments that it stopped me cold. The veteran in Building 207.
Oh, that story. It just perfectly encapsulates the administrative failure. So you have a veteran living in on-campus housing. He needs to get to the on-campus hospital a distance of, what, maybe a mile?
Less, probably. Inside the gates.
Inside the gates, he takes an ambulance. And because of how the billing and these bureaucratic zones work, he gets hit with a $3,000 ambulance bill.
And it was sent to collections.
Sent to collection.
That is just... It's absurd. We're talking about restoring warrior ethos and building this massive monument to independence, but the guy can't get a ride to the hospital on his own campus without ruining his credit.
It just highlights the massive disconnect between high-level policy wins and the gritty daily reality. A policy doesn't mean a thing if the billing department sends you to collections for getting sick.
And that disconnect isn't just happening in LA. This brings us to the national shakeup. We found some fascinating internal chatter from VHA Human Resources about a reorganization starting this year.
Yes, early 2026. This is the macro view. The leaks suggest a plan to drastically cut the number of VISNs.
Okay, and VISNs are Veterans Integrated Service Networks, sort of like regional HQs.
Think of them like regional corporate offices, yeah. Right now, there are 18. The plan is to slash that to 8 or maybe even 5.
18 down to 8. That's a huge consolidation. It sounds like they're centralizing power in D.C.
That's the admin side. But the number that really jumps out, the one that should make your ears perk up, is the money.
The new community care contract.
Right. A new contract vehicle with a ceiling of $1 trillion over 10 years.
1 trillion with a T. That's the GDP of a mid-sized country.
It's an astronomical figure, and it signals a massive shift toward paying for care outside the VA system. But here's the catch. While they're getting ready to spend that trillion on private doctors, the leaks say they're also eliminating 25,000 long vacant positions inside the VA.
Okay, let's clarify this. We saw the term scuba veteran used in some of these discussions. That sounds like a code word.
It's internal slang. Scuba, like diving deep below the surface to find things hidden in the books. So the scuba veteran explanation is that these 25,000 jobs aren't people getting fired today.
They're billets open positions that have been vacant for a long time.
For a very long time. And the administration is just deleting the position entirely to clean up the books.
So nobody loses a paycheck, but the job just vanishes.
Exactly. And the nuance here, and this is why the staff is panicked, is that it creates what they're calling a permanently understaffed reality. If you're a nurse on a short-staffed ward, you survive because you hope that open position will eventually be filled.
But once you delete the billet,
help isn't coming. That share is gone forever.
And this ties right back to that trillion-dollar contract. The administration frames this as broader choice. You get to go see a private doctor. It sounds good. Who doesn't want choice?
It sounds great. But critics and a lot of staff, they fear this is a stealth move toward privatization.
Yeah.
That the VA becomes just an insurance payer, not a healthcare provider.
And there's a real risk here that isn't talked about enough. The blacklist issue.
The blacklist, yeah. You mean private doctors refusing to see certain veterans?
Well, not outright refusing.
It's not personal, it's economic. A private practice runs on volume. A standard insurance payment covers a standard 15-minute visit. But veterans often have complex needs, combat trauma, TBI, behavioral flags.
So they might need 45 minutes or a ton more paperwork.
Exactly. The private doctor looks at the file and thinks, I lose money on this patient. So they can effectively blacklist complex cases. The private sector takes the easy surgeries, the simple checkups, and they profit.
And the VA is legally required to take everyone else.
So you risk this death spiral where the VA shrinks, loses its staff, and is left with only the most difficult, expensive, and heartbreaking cases, with fewer resources than ever.
That is a terrifying feedback loop.
It really is.
So the big question is, are we saving the VA by relieving pressure, or are we slowly dismantling the only system designed to understand the unique culture of the warrior?
That's the question.
But look, I don't want to paint a picture that's just entirely bleak. Because while the administrators are fighting over org charts, the scientists have been busy, and
Yeah.
we found some really incredible movement on the medical front.
Absolutely. Amidst all the turmoil, the science is advancing. And what's interesting is it's moving away from the old take a pill model. You just have to look at the Beacon Act.
This is the new bill from Reps. Bergman and Elfrith aimed at traumatic brain injury, TBI.
Right. And it explicitly acknowledges that traditional meds often fail for mild to moderate TBI. So the Beacon Act is designed to provide grants for alternative therapies and partnerships.
It's the government basically admitting the old toolkit isn't working.
Pretty much.
So what's in the new toolkit? We saw some research in these briefs that felt like real aha moments.
Let's start with suicide prevention. For years, the focus has been on depression, but new research is looking at circadian rhythms. They're testing something called morning light therapy.
Morning light therapy. I have to be honest, that sounds a little basic. You sit in front of a lamp.
It sounds simple, but the mechanism is really sophisticated. The research shows that sleep disruption, fragmented sleep, nightmares, is a massive physiological trigger for suicidal ideation.
It stops the brain from regulating emotion.
Right. This therapy uses specific wavelengths of light to hit the suprachiasmatic nucleus in the brain, and it forcefully resets the body clock.
So you fix the sleep, you stabilize the emotion, you lower the risk.
Precisely. You treat the physiology, not just the psychology. And on a similar note of simple but effective, there's the folic acid research.
Oh, yeah.
Large-scale studies are showing that simple folic acid supplements, we're talking pennies a day, are associated with a huge reduction in suicidal attempts.
That's incredible. So low cost, so low risk. Now, we have to talk about the Parkinson's breakthrough. This one just blew my mind. We've always thought of Parkinson's as a brain disease.
And it is, but the cause might not start in the brain. Researchers have found a link between a specific gut bacteria, Desulfovibrio vulgaris, and Parkinson's.
So the call is coming from inside the stomach.
In a way, yes. The theory is that this bacteria produces compounds that travel up the vagus nerve to the brain and trigger the damage. This changes everything.
So in the future, we might treat or prevent Parkinson's with what? Probiotics? Diet changes.
Exactly. Targeting the gut before the brain ever gets sick.
That's a complete paradigm shift. And speaking of shifting paradigms, I want to bring up one we almost missed, but it's huge. The opioid research. A drug called acetazolamide.
I'm so glad you caught that. This is a classic example of drug repurposing. It's an old drug used for heart failure or altitude sickness. But they found that in mice, it was able to reverse opioid withdrawal symptoms.
Wait, reverse them? Like stop the withdrawal?
Yes. It seems to block the specific signaling pathway in the amygdala that causes the pain and panic of withdrawal. If this translates to humans, it could be a silver bullet for the opioid crisis.
That would be game-changing.
Absolutely.
There was one more medical note I wanted to flag, specifically for our Vietnam vets, the Agent Orange link.
This is crucial, actionable intel. Researchers have identified a new, specific link between Agent Orange exposure and acral melanoma.
Which is a skin cancer, but not the usual kind from the sun. Right.
Correct. It appears on the palms of the hands and the soles of the feet, areas that don't usually see the sun.
So if you're a vet who is exposed, you need to be checking your palms and your soles. That is a specific life-saving piece of advice.
It is. And finally, on the tech side, there's Project Reach BET. It's using AI to analyze clinical notes to predict suicide risk before a crisis happens.
So it's looking for patterns in language, subtle shifts in tone that a human doctor might miss in a rushed 15-minute appointment.
Using big data to be proactive.
But again, and I hate to be the buzzkill here, we have to circle back to the reality. You can have AI, light therapy, gut bacteria breakthroughs, but if a veteran is sleeping in a tent, does any of that really matter?
That is the ultimate bottleneck. It brings us right back to housing as healthcare. And we did see some movement in California with Prop 1. Governor Newsom announced over $100 million for new veteran homes.
Mather Veterans Village and converting the Palomar Motel.
Right. It reinforces that housing first model. You can't treat PTSD if the patient doesn't know where they're sleeping tonight.
But this is where the rubber meets the road. Mission Roll Call released a survey of 1.3 million veterans, and the data shows this massive disconnect between what the VA reports and what veterans feel.
You're talking about the suicide statistics.
Yeah.
The official VA stats say we lose 17.6 veterans a day, but independent analysis, which includes deaths of despair, overdoses, things not strictly classified as suicide, suggests the number is actually 44 a day.
44. That's
That's
shocking. Why is that gap so big?
It's all methodology. The VA has a strict clinical definition. These groups are looking at the broader picture of self-destruction. But the takeaway from the vets in that survey was crystal clear.
What was it?
They don't care about the stats, and they don't care about the political debate over privatization. They care about wait times.
They just want to see a doctor.
Exactly. They want specialty care now, whether it's inside the VA or out in the community. They are tired of being pawns in this ideological battle. They just want the system that works.
So let's try to pull this all together. It's 2026. The VA is shrinking administratively, cutting those 25,000 billets. It's expanding financially with $1 trillion for private contractors. And it's evolving scientifically.
It is a system in total flux, and I keep going back to that West LA campus. It really is the perfect metaphor. You have these grand promises of a national center for warrior independence, the president signing orders, billions flowing.
And yet, a veteran gets a $3,000 ambulance bill for a 1-mile ride inside the gates.
The grand vision colliding with the broken machinery. And that is the challenge for the next few years. Can the VA modernize without losing its soul?
Can it integrate with the private sector without abandoning the difficult cases that the private sector refuses to touch? It leaves you with a really uncomfortable question. If we funnel that $1 trillion into private community care, are we saving the VA by relieving the pressure, or are we just funding its replacement? And if we replace it, do we lose the only place that truly understands what it means to serve?
That is the question every listener needs to ask. And don't just watch the headlines about reorganization. Watch where the money goes. Watch where the research goes.
Because that's where the real story is. Thanks for diving in with us.